Hi, this is Matt Fields. I'm an emergency physician at Thomas Jefferson University in Philadelphia. And today I'm going to be talking about musculoskeletal ultrasound in two parts. This first part is going to look at muscles and tendons. So the outline, we're going to talk about indications for musculoskeletal ultrasound, go over technique, review the normal sonoanatomy. Then we're going to look at muscle injuries, tendinosis, and how to use ultrasound for sonographic tendon exploration. Indications for musculoskeletal ultrasound can follow after traumatic causes or non-traumatic causes. Traumatic causes tend to be direct trauma, which will be blunt or penetrating, or indirect trauma, which is often due to a stretch injury. Non-trauma indications for musculoskeletal ultrasound include signs of inflammation or infection, such as cases of tendinosis, which we'll talk about later, or an abnormal musculoskeletal exam in which you think a muscle or tendon pathology might be the cause. When you do musculoskeletal ultrasound, pretty much you're always going to want to use your high frequency linear probe. This gives a good resolution, and sometimes whenever you're looking at structures that are very superficial, you may want to use a standoff pad, or when you're looking at the fingers, you might want to use a water bath. Your technique, like you do in any other scan, you want to hold the probe kind of like a pencil and rest your fourth and fifth digits on the patient. You want to scan systematically through the area of interest in two orthogonal planes. With musculoskeletal ultrasound in particular, you want to examine the area of tenderness, which is often your likely site of pathology. You always want to make sure that you complement your exam with a contralateral examination. So when you're looking at the extremities, you want to take a look at the normal side to compare. And obviously there's the caveat of maybe a patient having a bilateral pathology, but that's pretty rare. You also maybe want to sometimes apply light transducer pressure, which may help reveal a fracture or tendon pathology. And sometimes having dynamic examination, having the patient move the extremity may help reveal muscle tears, ruptures, or tendon pathology, so that can also complement your exam. Using a water bath, as I mentioned before, can be useful, especially when you're looking at smaller parts like the fingers and toes. You don't need to use any gel, as the water provides an acoustic medium. And this is especially good for kids, because sometimes when kids have a injured finger or toe, they don't want you to touch it but with a probe, but they don't mind putting it in water. So we'll do a quick review of soft tissue sonoanatomy. Starting closest to the probe, the thin hyperechoic layer is the skin. Beneath that, the subcutaneous tissue is hypoechoic with some reticular hyperechoic strands running through it. Immediately beneath that, we often see a hyperechoic line that represents the superior muscle fascia, and below that is the actual muscle body, which appears to be speckled when you're looking at it in transverse plane, or feathery or pinnate when you're looking at it in longitudinal, which we see transverse on the left here and longitudinal on the right. Tendons can be found at the end of the muscle attaching onto the bone, and often have a fibrillar appearance or a brush pattern. So you can see in the image on the left we have a longitudinal image of a tendon, and on the right we have a transverse. Again, just think of it as looking like bristles of a paintbrush. Bone is often visualized beneath muscle or at the site of tendon insertion, as is demonstrated here. Bone is calcified, causing reflection of ultrasound waves, and therefore is seen as a hyperechoic line with acoustic shadowing. And in real time, we can see as the patient moves the extremity, the tendon sliding back and forth. Tendons have a unique property due to their fibrillar structure called anisotropy, which just means directionally dependent. So what we're talking about is when the ultrasound beam hits the tendon directly at 90 degrees, there is a strong reflection. However, when the angle is changed, the reflection is lost and the tendon quickly becomes hypoechoic. So here on the left, we see an angle right at 90 degrees. I'm going to highlight the tendons for you in both images. And then when we change the angle, they immediately become hypoechoic or almost anechoic, and that's anisotropy. Here this is seen in real time as the sonographer fans the probe over the biceps tendon and the bicipital groove. Point out the tendon here. Right, we're at 90 degrees and now we're off angle. So moving on to some pathology, let's first talk about muscle injuries, which are classified as grades 1 through 3. Muscle injuries can occur from either direct or indirect trauma. In a grade 1 injury, the muscle sheath and fascia remain intact. So what we might see on an ultrasound is swelling or enlargement of the muscle body. We might see loss of normal echo texture of the muscle, or in a little bit more severe cases, we might see an intramuscular hematoma forming. In grade 2 injuries, we get tear of the muscle sheath and fascia, and this might lead to an intermuscular hematoma. In grade 3 injuries, we get complete rupture of the muscle body, including the sheath and fascia, and this results in a swollen retracted muscle with surrounding hemorrhage. Here's an example of a grade 1 injury. We see the normal pinnate echotexture on the left compared with the less well-defined echotexture on the right. Also, there appears to be some fluid possibly traveling between the muscle fascicles on the right, as seen by this arrow. In this clip, we see a discrete heterogeneous region within the muscle belly in the biceps. This patient had a sudden onset of pain while lifting a heavy object and developed a hematoma of the brachioradialis muscle. Note here the heterogeneous appearance of the hematoma, which is common in intramuscular hematomas and may vary with the age of injury and amount of clotting and fibrinolytic activity. I'm just going to point this out here. We see this circumscribed area. We see the muscle belly over here. We see the hematoma developing over here. And then we're over here, we see there's normal muscle as we scan through. We see the humerus bone beneath it. Another example is seen here in someone with sudden onset calf pain while playing tennis. Again, there is a discrete hypoechoic region within the muscle belly, which is this case, the muscle is the gastrocnemius. In these two examples, the muscle sheath and fascia appear to be intact. If these structures, specifically the fascia and the muscle sheath were not intact, we might expect to see an intermuscular hematoma, as we see in this next example. Here we see a very similar image with the gastrocnemius and soleus muscle, but now the hematoma is layering in between the two muscle groups, and this is what we call a grade 2 injury. Finally, a complete tear of the muscle belly with retraction and surrounding hemorrhage is a grade 3 injury, as we see here in this example of a quadriceps muscle tear. Moving on to tendon pathology, similar to muscle injuries, tendons can be torn, usually from overstretch, resulting in either complete or partial tears. Complete tears result in 2 separate fragments with surrounding hemorrhage. Partial tears result in one or several hypoechoic regions in the tendon body that are not anisotropic. We'll show examples of that. In addition, partial tears, either tears, can result in swelling of the tendon. Complete tears are typically obvious on physical exam. However, sonographic confirmation is desirable. Here we see a right patellar ligament injury with retraction and swelling of the distal and proximal tendon complexes, which we'll highlight here. Again, comparison to the other side reinforces the pathologic finding. Here we see a quadriceps tendon rupture on the right with a normal comparison on the left. You can see the retracted tendon floating in some fluid here. Partial tears are more difficult to diagnose from physical exam alone, as the patient's range of motion is often preserved. This patient had sudden pain from stepping backwards onto a hole, and a Thompson test was normal. On ultrasound, we see swelling of the Achilles with a small hypoechoic region that was present despite a 90-degree angle of inclination, also known as loss of anisotropy of the tendon. I'll highlight this for you. There's the tendon with swelling, and we see that dark area that's hypoechoic and did not change even with a 90-degree angle of inclination. This represents a tendinopathy. Again, comparison to the other side shows evidence of hemorrhage within the musculotendinous region of the Achilles with swelling and heterogeneous appearance and loss of the normal fibular tendon pattern. As we see here. Over here we see a normal, nice brush pattern on the normal side. In transverse, we see again swelling and surrounding hemorrhage. On the left, we have the normal with a nice smooth brush pattern, whereas on the right, we see surrounding fluid, which is likely blood, and a swollen, thickened tendon with kind of loss of the normal echo texture or brush pattern. Here's an example of swelling and loss of anisotropy in a biceps tendon. You see on the left here the swollen tendon with an area of hypoechoic area, the loss of anisotropy, compared to the normal on the right. Another potential use of musculoskeletal ultrasound is to evaluate the integrity of a tendon after a laceration. In this example, a patient had punched a metal sign and sustained a laceration and underlying fracture with decreased range of motion. Local exploration of the laceration did not reveal tendon injury, and on ultrasound, the tendon also appeared to be intact with normal fibrillar brush appearance without any areas that failed to demonstrate anisotropy, which I'll highlight here. We see the laceration here, the fracture here, and in between the tendon appears okay. Patients presenting with a clinical concern for tendinosynovitis, as this patient with a swollen erythematous sausage-like digit, can be evaluated also with ultrasound. Fluid can be seen surrounding the tendon. Here we see the tendon, and here are the areas of fluid. As we always do in ultrasound, scanning in two orthogonal planes can be useful. In this example, looking in transverse makes the fluid even more easily appreciable. Again, we also see a hyperechoic tendon that has a little bit of loss of that fibrillar echo texture, suggesting inflammation. This patient was taken to the OR and washed out. So in summary, for musculoskeletal ultrasound, we want to use a high-frequency probe. We want to allow the patient to guide us to the area of maximal tenderness and also perform a contralateral examination. We want to remember that intramuscular hematomas may have variable appearances from hypoechoic to hyperechoic depending on the age. Anisotropy affects the sonographic appearance of tendons, so we want to make sure we visualize all tendons right at 90 degrees and off 90 degrees to determine whether there is pathology. And we want to view all muscles and tendons in two orthogonal planes. That's my references. I'd like to give special thanks to Dr. Anthony Dean and Dr. Nova Panebianco, who were my fellowship mentors and also helped provide many of the images and clips seen in this talk. As well, I'd like to give special thanks to the AEUS Narrated Lecture Series team, Dr. Megan Kelly-Herbst, Dr. Reese Lewis, and Dr. Angela Teplo, who helped provide edits and feedbacks to the talk.